continuation for the inflammatory muscle disease. Sorry for the interpretation. This is the second part of inflammatory muscle disease, which we will be discussing further. Okay, so coming to dermatomyositis laboratory manifestations. Okay, so patients would be having skin lesions, patients would be having muscle weakness, and if the patient is having any other features like interstitial lung disease, okay, and the patients are having a risk of malignancy. This is what we discussed in the last video, and now we would see how do we diagnose these patients with dermatomyositis. See, in polymyositis, most of the time the CPK would be elevated, whereas in dermatomyositis and inclusion body myositis, you might expect a normal muscle enzyme, that is the creatinine phosphokinase elevation enzyme. It would be normal. Serum C-creatinine phosphokinase levels are elevated in about 80% of the patients, but in 10% of the patients, creatinine phosphokinase would be normal. So, what are the causes of a patient who is having a normal CPK? It's a very commonly asked MCQ in our DM examination. So, the first reason would be a very early diagnosed inflammatory muscle disease, very late inflammatory muscle disease, where you have the muscle gone for complete atrophy when there is no inflammation in the muscles. And number 3 is dermatomyositis. Number 4 is inclusion body myositis. Number 5 is when the patient is having malignancy. Okay, and number 6 is anti-CPK antibodies. When the patient has antibodies to CPK enzyme per se, you can have a normal CPK levels. Okay, so these are potential causes of a normal CPK level, so you must be knowing this. So according to Harrison, 2 important diseases can have a normal CPK. One is dermatomyositis and the second is inclusion body myositis. Okay, anti-nuclear antibodies. So regarding this anti-nuclear antibodies, they are positive, but it is usually non-specific. So we don't do ANA as a routine unless and otherwise we suspect an overlapping inflammatory muscle disease. That is, you're having a patient with lupus and muscle weakness. So in that case, you would look for ANA. You're seeing a patient with MCTD and muscle weakness. In that patient, ANA is important. You see a patient with scleroderma and myositis. In that patient, ANA is important. Whereas when a patient is developing an idiopathic inflammatory muscle disease, doing an ANA would be of no use most of the time. Okay, sometimes patients might have a cytoplasmic pattern which could be suggestive of a inflammatory muscle disease. Okay, so 3 to 4 to 5 important autoantibodies that you must be knowing, and all these 5 autoantibodies are potential MCQs. Question number 1: most common autoantibody in dermatomyositis, it is antisynthetic antibodies. Okay, so this is very important. And second thing, the autoantibodies that are associated with malignancy, it is TIF1 gamma, that is transcription intermediary factor 1 gamma. Okay, this is one thing. And nuclear matrix protein NXP2. So NXP2 and TIF1 gamma are associated with malignancy, and MDA5 is associated with clinically amyopathic dermatomyositis. I talked about this. They would have a very severe skin lesion, they would have digital ulcers and rapidly progressive ILD. And as I discussed, TIF1 gamma and NXP2 are associated with cancer, and a benign dermatomyositis is being associated with anti-MI2. So these patients would be having a mild muscle weakness and skin lesions that are usually responsive to treatment. So autoantibodies with malignancy must be known: TIF1 gamma and NXP2. MDA5, amyopathic dermatomyositis, rapidly progressive ILD, digital ulcers, you must be knowing this. And last but not the least is your MI2, which is having a very good prognosis. Okay, then what they have discussed is about EMG. So in any kind of inflammatory muscle disease, you would be looking for an increased insertional activity. That is, when you put a needle inside the biceps will have some irritation because there is inflammation in the muscle. Okay, and that will produce an insertional activity. Okay, sometimes even before you put a needle, while recording the electrode from the muscle, you might have a spontaneous activity. Okay, it's called as a positive sharp wave or fibrillation potentials. Okay, and so these are all features of an inflammatory muscle disease. And when you have early recruitment of small amplitude motor action potentials, that is again suggestive of a muscle disease. But these findings are going to be non-specific. It is not exclusively present for dermatomyositis alone, it can be present in any kind of myopathy. So insertional activity and spontaneous activity is suggestive of some irritation in the muscle, whereas short polyphasic compound motor action potentials with early recruitment are common for any kind of myopathy. Okay, MRI is a very good tool. So in some cases, patients would not be affording a biopsy, or patients would be on treatment for inflammatory muscle disease, and patients would be having muscle weakness. You would not know whether the weakness is because of muscle edema or fatty replacement. In such cases, MRI would be very useful. Okay, so this is in the rectus femoris muscle. Okay, you find lot of stir intensities that is happening here. And this is a picture of inclusion body myositis, where you have intensities not in the rectus femoris but in the vastus lateralis and vastus medial. So what you see as hyperintensities in a stereo imaging is nothing but your muscle edema. So when you have muscle edema, you can say it is because of muscle disease activity. When you have fibrofatty replacement, see here in this picture, so this is common for any kind of muscle disease. Okay, so when you have muscle inflammation, you call it as muscle activity. So when you have a lot of fibrofatty replacement, you call it as fibrofatty replacement, so it's muscle atrophy. So, and the next important use of MRI is, by doing an MRI, you can select the muscle in which you need to do a biopsy. So this is another important role of getting a MRI done before muscle biopsy. Okay, so what do you see here in dermatomyositis? So based on the observation seen, the characteristic observations of dermatomyositis are, you will have a perifascicular inflammation followed by atrophy. Okay, and sometimes you would be having a perivascular atrophy. So perifascicular, and this is not shown in this picture. So perifascicular atrophy is characteristic of inflammatory muscle disease dermatomyositis, and because they are atrophic, they are looking basophilic, that is dark blue in color. See, dark blue in color. So this area is looking dark blue in color. They are looking basophilic because they have gone in for atrophy. So when you find the perifascicular fibers going in for atrophy, the diagnosis is more in favor of inflammatory muscle disease dermatomyositis. Okay, and you can have a perivascular atrophy also in these patients. One staining, immunohistochemistry staining, that is very specific for dermatomyositis is the myxoprotein A staining. So when you do a myxoprotein A staining, so in the perivascular area, you will have darker staining of myxovirus A protein, which should be followed by a lighter tinge in the intermediate area, and which should be followed by an absence of tinge of myxovirus protein in the centrally located fibers of the fascicle. So presence of myxovirus protein A, perivascular atrophy is all indicative of a dermatomyositis. Okay, so initially it was thought that, and when you look at the immunohistochemistry of the inflammatory cells, it is predominantly a CD4 cell mediated immunity, and CD4 inflammation and MHC class 2 expression would be more. But it was thought that there is a lot of T cell activation and autoantibody production, because everything was just around the blood vessel. So there might be some immune complexes forming complement mediated destruction. So this was the thought in dermatomyositis initially. But now what they have proven is that the immunoglobulin deposition is largely absent on the endothelial cells. So though you have a lot of antibodies here in dermatomyositis, you don't have any immunoglobulin molecules deposited in these areas. Okay, so the main reason for perifascicular and perivascular atrophy is not the antibodies, it is not the complement, but the newer hypothesis is a microvasculopathy. It is this microvasculopathy that would cause nail changes in your nail bed capillaries, and it is the same microvasculopathy that is going to cause the skin damage and the muscle damage in patients with dermatomyositis. And all of these things are mediated by interferon beta. So there should be some amount of viral trigger, and that is why type 1 interferons, antiviral immunity, We talked a lot in innate immunity class, which again I am stressing. So interferon 1 mediated pathway, again similar to lupus, there is a lot of scope for interferon beta, that is your type 1 interferons, right? Okay, now about your prognosis. Okay, see, per se, if there is no malignancy, the prognosis is good. I told you the most potential muscle disease that is associated with malignancy is dermatomyositis. Leaving alone the malignancy, the prognosis is very, very good. Okay, and you have a few poor prognostic factors that is almost similar to that what you see in polymyositis also. So when a patient has cancer, the prognosis is poor. When the patient's age is high, it is poor because response to treatment is poor. When there is a coexistent ILD or a cardiac involvement, the prognosis is poor. Late treatment or previous inadequate treatment are indicators of poor prognosis. And yes, there is a very, very dangerous musculoskeletal complication that occurs predominantly in children in inadequately treated cases or lately treated cases. The answer is calcinosis cutis. Okay, so this is the matter what you need to know about dermatomyositis. Okay, so finishing dermatomyositis, now let us go and look into the table on dermatomyositis. Okay, so in dermatomyositis, you have proximal weakness more when compared to distal weakness. Again and again, I am telling you, one of the inflammatory muscle disease with a normal CPK, the answer is dermatomyositis and inclusion body myositis. The autoantibodies, what is stressed now or otherwise called as myositis specific antibodies, MDA5 myopathy dermatomyositis, rapidly progressive ILD, digital ulcers, and severe skin rashes. TIF1 gamma and NXP2 malignancy and MI2 is associated with a benign dermatomyositis and a very good prognosis. So this is what we covered in laboratory features. Perimysial, that is perifascicular inflammation, perivascular inflammation, interferon 1 regulated protein. So you have MHC1 myxovirus protein deposition. Okay, and apart from this, the cells what you see here is CD4 T cells. You can have dendritic cells, you can have B cells, you can have macrophages. See, so dermatomyositis is very peculiar to have CD4 deposition. Okay, that is one thing. And as you all know, MHC1 expression is decreased, is low in a normal skeletal muscle, and in majority of inflammatory muscle diseases, the MHC1 expression is increased. So this is a very important factor. So the response to therapy is very good. Okay, and patients can have a myocarditis, poor prognosis, ILD, poor prognosis, malignancy, poor prognosis, vasculitis, yes, it's again having a prognosis. Okay, especially in children, develop a lot of cutaneous vasculitis. Coexistence with other CTDs is a commonly expected phenomenon. Okay, dermatomyositis is associated with a lot of autoimmune diseases because again it is a T helper mediated disease that can be associated with any kind of T cell mediated autoimmune disease. Now we move on to the polymyositis. So if you want to talk about polymyositis, so this polymyositis is going to be a diagnosis of exclusion. So a patient would present with insidious onset, symmetrical, proximal more than distal, pure motor muscle weakness. Okay, so if these patients, you have ruled out the other possible causes like dermatomyositis, inclusion body myositis, necrotizing myopathy, okay, antisynthetic syndrome, you have ruled out vitamin D deficiency, you have ruled out hypothyroidism, you have ruled out drugs, you have ruled out all potential causes of proximal muscle weakness, and you have done a muscle biopsy, and muscle biopsy is confirmatory for the same, you would make a diagnosis of inflammatory muscle disease, polymyositis. So similar to your counterpart dermatomyositis, your polymyositis patients can also have myocarditis, they can have ILD, they can have arthritis, and yes, they are also at risk of cancer. But when you compare the risk of cancer with dermatomyositis, the risk is relatively less. But the hypothesis, what they say is, previously there were no much classifications of inflammatory muscle disease. It was either inflammatory muscle disease dermatomyositis or inflammatory muscle disease polymyositis, and later people recognized that one of the substitute of IBM, inclusion body myositis, had a poor prognosis, that is again included in polymyositis, not associated with malignancy. Muscle dystrophy is not associated with malignancy, and these people have been misdiagnosed and pulled up in the data of polymyositis, and that is why the risk of malignancy is appearing to be lower. But whatsoever, always rule out a malignancy in a patient with inflammatory muscle disease. For MCQ purpose, answer is dermatomyositis. Yes, polymyositis also there is a risk of malignancy. It is relatively less when compared to dermatomyositis. Okay, so what I said in polymyositis is in majority of the time CPK would be elevated. This is what I have been stressing very clearly. So patient is having a normal CPK. I told you one of the causes of normal CPK is dermatomyositis. So patient is having proximal muscle weakness. Patient is having a normal CPK. Patient is not on steroids because steroids can cause patients can cause with steroids can have a normal CPK. Okay, just a minute. Okay, normal CPK. You should always suspect of inclusion body myositis. So EMG, skeletal muscle imaging, again the same phenomenon. They will have muscle edema in the MRI, and EMG will be showing a insertional activity or spontaneous activity with CMAP being low and polymorphic waves, polyphasic waves with early recruitment. So all those things are non-specific, and this is not going to make you fetch a diagnosis. Okay, so when you look at the histology, in addition to your perimysial inflammation, you find lot of endomysial inflammation. See, you don't see any fascicle here, but in between the non-necrotic muscle fibers, you find inflammatory infiltrate. So this is very characteristic of polymyositis. Endomysial infiltrates is characteristic. And when you see, again, patients would be having MHC1 expression and CD8 T cells would be expressed in heavy quantity. So this is one thing you must be understanding. Okay. And polymyositis, yes, the treatment is similar to dermatomyositis. You need to give immunosuppression, steroids followed by steroid sparing agent. But the response of dermatomyositis is better when compared to polymyositis. Okay, but again the problem comes with the previous series that majority of the patients included under polymyositis were not truly polymyositis. So when people excluded immune-mediated necrotizing myopathy, IBM, inclusion myopathy, muscle dystrophies, the response would be almost similar to that of dermatomyositis. Okay, so again the poor prognostic factors are the same: cancer, age, lung or cardiac involvement, lately treated or inadequately treated polymyositis. All these are going to have a poor prognosis. So now I'm going to the chart again. So what is the peculiar difference that we found in polymyositis? Okay, so there is no rash that we know. CPK is almost always elevated. So this function, this thing you should not forget. In addition to perivascular or perifascicular inflammation, you have a characteristic endomysial inflammation. And yes, you have ubiquitous expression of MHC1, which is a characteristic of any inflammatory muscle disease. CD8 inflammation is a very important term you should not forget. Response to immunotherapy is good. Yes, similar to the above diseases, they can have other features of similar to what you have seen in patients with dermatomyositis. They can be associated with CTDs, they can be associated with ILD, myocarditis, they can also be associated with malignancy. So polymyositis is no inferior or no bad in having the other associated conditions. So with this we finish the second inflammatory muscle disease. So treatment will cover up as a whole at the end of the class. Okay. Now going to the third one, which is called as the overlap syndrome. Overlap syndrome means the patient has muscle disease, the patient has either dermatomyositis or polymyositis as per the criteria, but still patient is having a coexistent connective tissue disease like scleroderma, MCTD, Sjogren, RA or SLE. And again the response to this group is going to be better. Okay, that is the next thing. And the next category is necrotizing myopathy. So in all dermatomyositis and polymyositis, we just saw a few necrotic fibers and lot of inflammation. But what you would find in necrotizing myopathy is lot of necrosis, okay, lot of necrosis with paucity of inflammatory cells. I'll show you a picture of the same. Okay, so you find inflammatory cells here, okay, but it is not as heavy as you saw in polymyositis. You have inflammatory cells, they are in paucity, and along with that you have some muscle cells going in for necrosis. So when you have necrosis with paucity of inflammatory cells, you should think of a necrotizing myopathy. Okay, there are two categories of necrotizing myopathy. Okay, the first one being SRP associated necrotizing myopathy, and the second being HMG-CoA reductase, your statin inhibiting enzyme. Okay, so that myopathy. Okay, so patients with HMG-CoA reductase myopathy would be having anti-HMG-CoA reductase antibodies. Okay, so this can occur patients who are on statins, and they can also occur in patients who are not on statins. Okay, so usually when patients have or take overdoses of statins, patients develop myalgias, rhabdomyolysis, and muscle weakness. And once you stop the statins, they would come out. So this is a non-immune mediated myopathy because of statins. But when these patients continue to have myopathy despite stopping statins, so this is characteristic of immune mediated necrotizing myopathy. So when you do a muscle biopsy, you would find necrotic fibers, regenerating fibers, and paucity of inflammatory cells. Okay, next. So this is one category, and SRP category is again a worse prognostic category. Patients would be having a subacute type of onset of disease with aggressive manifestations and relatively refractory course. So even in necrotic myopathy, you would have elevation of CPK levels because the muscle is necrosing, so the inflammatory enzymes has to be released into the circulation. You would find either HMG-CoA reductase antibody or anti-SRP antibody. Again, EMG and MRI is going to be non-specific. Okay, muscle biopsy I discussed with you. The prognosis is again going to be poor. It is very difficult to treat. It is very difficult to treat, and sometimes patients would have to be only on intravenous immunoglobulin, which could be the only proper option. And sometimes the necrotizing myopathy might be as severe as the patient would develop a lot of deformities, muscle atrophies, and sometimes you might think it is not an inflammatory muscle disease, but it is a limb girdle muscle dystrophy. So being a part of inflammatory muscle disease, there is an increased risk of cancer. So patients with HMG-CoA reductive myopathy should have a malignancy workup. So having finished this part, now let me go into the table again. So see the table. Okay, there is no rash here. Proximal is more than distal. CPK is usually elevated, and you can find HMG-CoA or SRP autoantibodies. And you have necrotic muscle fibers, paucity of inflammatory infiltrate. So when they say necrotic muscle fibers, paucity of inflammatory infiltrate, you should think of necrotizing myopathy. Macrophages in necrotic fibers which will phagocytose the muscles, that is called as myophagocytosis. And yes, there is a response to treatment, but the prognosis is poor. They are associated with malignancy, they are associated with CTDs, and HMG-CoA reductase inhibitor can be triggered by statins. So this is again the thing what we have completed on inflammatory muscle disease. Okay. The next group of diseases is very peculiar. My favorite inflammatory muscle disease is your antisynthetic syndrome. So you have your Jo1 antibodies, which are the amino acid tRNA synthetase autoantibodies. When present, they are associated with the spectrum of diseases where you have fever, Raynaud's phenomenon, and non-erosive arthritis, myositis, interstitial lung disease, and last but not the least, your mechanics hands. Okay, and sometimes in addition to the mechanic hands, patients might have a rash which is similar to dermatomyositis also. So amino acid tRNA synthetase syndrome is closely related to dermatomyositis because the histopathological features are almost similar to that of a inflammatory muscle disease, dermatomyositis. But there are subtle differences with which you can find out whether it is an amino acid tRNA synthetase syndrome or it is something else. Okay, so the most common MSA is amino acid tRNA synthetase syndrome is anti-Jo1. Okay, CPK is usually elevated, and when you have an ILD, you will have a reduction in your FBC, in your PFT, and you would have MRI showing the abnormalities similar to DM, PM, and in necrotizing myopathy. In EMG would also be non-specific. So coming to the biopsy, you have perifascicular atrophy, perimycial atrophy with edema. Okay, so perimycial fragmentation, perimycial damage, perimycial atrophy. So with edema and fragmentation. So this is characteristic. And these connective tissue intensely stains red with alkaline phosphatase. So there is excess amounts of alkaline phosphatase in these areas, in the perifascicular areas, right? So this is one fascicle, this is another fascicle, this is another fascicle. In the perifascicular area, what you find is excessive alkaline phosphatase. And again, a membrane attack complex is created over the non-necrotic fibers, which are again specific for your amino acid tRNA synthetase syndrome. So when these features are there, so we recently had a patient with inflammatory muscle disease with anti-EJs. Anti-EJs, another patient, another type of myositis specific antibody coming under the same group of ASS antibodies. The patient had an EJ antibody, but the patient did not respond to steroids well. Hardly the patient underwent just histopathological evaluation, and he was just to have inflammatory muscle disease. No specific type categorization was done, and no specific feature of a specific inflammatory muscle disease was obtained. In such patients, you should always do an immunohistochemistry with either alkaline phosphatase or membrane attack complex to look such characteristic patterns along with your perimyseal inflammation and perifascicular inflammation. Okay, just a minute. Okay, so this is one thing. So most patients respond to treatment well, but they are not as good as for dermatomyositis or polymyositis alone. But among the MSC antibodies, this is next to MI2, this is having a better prognosis. Okay, ILD can be refractory to treatment, and in contrast to what you studied in polymyositis, dermatomyositis, or immune-mediated necrotizing myopathy, the risk of malignancy is lesser, and lesser. Okay, so this could be a potential MCQ. The muscle diseases that are not associated with the risk of malignancy. Number one is ASS, and that is the reason why they have separated ASS from dermatomyositis, polymyositis. And number two is inclusion body myositis. So your dermatomyositis, immune-mediated necrotizing myopathy, and polymyositis are associated with increased risk of malignancy. Okay, now coming to inclusion body myositis. So before that, we'll go to the table and recheck this table. Would be easy to remember now. Here's the sex distribution and the age distribution which you've discussed already. Rashes might be present sometime. They can have the dermatomyositis rashes or they can have the mechanic's hand. I forgot to tell you what is the mechanic's hand. So when you see laborers and mechanics working, because of handling and doing a lot of manual labor, they develop eczematous reactions along the radial aspect of the index finger. So when you find such mechanic-like hands in a patient who is not involved in manual labor, you should think of a mechanic's hand with a radial eczematous reaction with a lot of furrowing. So that is characteristic of mechanic's hand. So if you want, I'll show you the picture of mechanic's hand so that if put in an MCQ, you should be able to answer it. Yes, so on the radial aspect you see some eczematous reaction. Okay, it is commonly seen in the index finger, but it can be seen on the other fingers also. Okay, so this is which is called as mechanic's hand. Okay, and your CPK would be elevated. Okay, you would have antisynthetic antibodies. Okay, similar to dermatomyositis, you have perimyseal, perivascular inflammation. You have staining of alkaline phosphatase, and yes, along with that you have MAC staining also. Okay, you find some amount of muscle damage with necrosis. When there is predominant necrosis and less inflammation, think of necrotizing myopathy. Okay, when there is predominant inflammation and less necrosis, okay, and patients are having myxoviral protein expression, it is dermatomyositis, alkaline phosphatase expression, ASS, MAC expression, again it is ASS. So similar to dermatomyositis, again it is the same CD4 dendritic cells, B cells and macrophages. So the histopathology of amino acid tRNA synthetase syndrome is almost near to what you see in a dermatomyositis. The response therapy is good here. And this is what is the spectrum of amino acid tRNA synthetase syndrome. Okay, now going into your next topic, the last topic of discussion in inflammatory myopathies is your inclusion body myopathy. Okay, when should you suspect inclusion body myopathy? Okay, you are seeing a patient with a pure motor weakness. His age is more than 50. Okay, he is a male. Okay, in addition to a proximal muscle weakness, if the patient is having a profuse weakness of your quadriceps. Okay, so as in this picture, I'll show you this picture of a patient with inclusion body myositis. There is gross wasting of vastus medialis. And here in this MRI, there is fatty replacement of vastus medialis and vastus lateralis with preservation of rectus femoris. So because of vastus medialis and vastus lateralis wasting, patients would be having frequent buckling. Okay, patients would be having weakness in your finger flexors, but the lumbricals would be maintaining the part of your metacarpophalangeal joints. Because your finger flexors are weak, your forearm muscles will go in for atrophy. Okay, so these are all very, very, very crucial clues that you might get in a patient with inclusion body myositis. So if you overlook these features, sometimes the weakness would be very, very subtle. Just two fingers would be able to difficult in folding will be there. So in such cases, you might falsely label these patients as polymyositis with a proximal and distal muscle weakness. Okay, and they might be debilitating, but it is a slowly progressive lesion. It progresses over about 15 years. So similar to ASS, it is also not associated with the risk of malignancy. Okay, CPK would be elevated. It is only slightly elevated. It is not as severely elevated as in other cases, and CPK can be even normal also. Okay, and cytop 5' nucleotidase, cytosolic 5' nucleotidase is an autoantibody that has been diagnosed in patients with inclusion body myositis. Okay, so in contrast to your dermatomyositis and aminoacyl tRNA synthesis syndrome, patients with polymyositis, okay, patients with polymyositis, patients with dermatomyositis, sorry, inclusion body myositis would be having an increased CD8 inflammation. Okay, so this is one important point you should remember. And there is involvement of flexor digitorum profundus and vastus medialis and vastus lateralis being profusely affected with sparing of rectus femoris muscle. So never go for a biopsy from a rectus femoris muscle. Always go from a vastus medialis or vastus lateralis, or wherever, do an MRI and find out wherever there is active inflammation, go for a biopsy. Okay, so in addition to the endomysial inflammation, CD8 inflammation, MHC1 expression, what you see here is inclusion. So the pink color one that you see as a round body here is a rimmed vacuole. And this rimmed vacuole is stained with the stain which is called as P62 stain. So a P62 stain positive rimmed vacuole is pathognomonic of inclusion body myositis. And while doing an internal microscopy, if you are able to find a tubular filamentous inclusion within the myonucleus, that is again suggestive of inclusion, and this inclusion is suggestive of inclusion body myopathy. And some of the muscle fibers lose COX expression, that is cytochrome oxidase expression. It's not cyclooxygenase expression, it is cytochrome oxidase expression. It is lost in patients with inclusion body myositis, and this could be another marker of inflammatory muscle disease, inclusion body muscle disease. Okay, so similar to lupus, similar to spondyloarthritis, similar to IBD, primary biliary cholangitis, in inclusion body there is a lot of talk about endoplasmic reticulum stress and autophagy. Remember in the last class on spondyloarthritis, we discussed how an endothelial reticular stress would cause a UPR response, unfolded protein response, and also trigger autophagy. Okay, so these are very, very important molecules in triggering autophagy, and that is why you have a P62 stain positive rimmed vacuoles. The prognosis is usually it's a progressive disease. The prognosis is poor, they don't respond to immunosuppressive therapy, but the life expectancy is not significantly altered in inclusion body myopathy. Though they are a very worst responders to treatment, they would remain with some amount of weakness. They might remain alive for even 15 years without any treatment, but still they would be doing good. So why should you know that there is IBM? Because IBM is most of the time mistakenly taken as inflammatory muscle disease polymyositis. So always look for special stains, always put a COX stain or always put a P62 stain to show that the patient is having a rimmed vacuole or absent cytochrome oxidase levels. Okay, so these are all the features what you should be knowing about in inclusion body myositis. So now going to the table again. Okay, so it is a male more than common female disease occurring in elderly, no skin rash. There is proximal muscle weakness and distal weakness, but there is preference for finger and wrist flexors, and wrist flexors, but the MCP flexion will be maintained by the lumbricals, and patients will be having knee buckling because of vastus medialis and vastus lateralis involvement with preserved rectus femoris power. right? And CPK would be increased or sometimes it would be normal also. Cytoplasmic nucleotidase antibody 1A is very, very important, and increased CD8 count, CD8 mediated inflammation is very important. MHC1 expression is important, rimmed vacuole is important, P62 positivity is important, COX negative fibers are important, ragged red fibers are important. Okay, and when you do an electron microscopy, you find tubulofilaments of size 15 to 18 nanometer. Okay, so these are all features. CD8 inflammation is again common to both polymyositis and inclusion body myositis. Okay, and you find large granular lymphocytes in inclusion body myositis. This is very specific. You don't find large granular lymphocytes in any of the inflammatory muscle disease. Response to therapy is minimal. Okay, because they have large granular lymphocytes, they can have a large granulocyte lymphocyte leukemia, LGL leukemia, lymphocytosis, sarcoidosis, and Sjogren syndrome. So these lymphoma things are always correlating with sarcoid and Sjogren. Always remember sarcoid and Sjogren lymphoma. All these three could be erroneously diagnosed in either of the other ways. So you have to be very cautious in maintaining the or making the diagnosis. So large granular cells are present in IBM, you should remember this. And large granular cell leukemia is common in patients with IgM because they have large granular lymphocytes being proliferating in your inflammatory infiltrate of the muscle biopsy. Okay, right. So with which we completed the table of Harrison on inflammatory muscle disease. Now moving on to the treatment. So treatment is going to be very, very, very simple. So if you have made a diagnosis of inflammatory muscle disease, the patient came to you with a pure motor weakness, no sensory weakness, preserved reflexes, hypotonia, proximal more than distal weakness, you think of muscle disease. Okay, and there is no fatigability, there is no sensory involvement, there is no fasciculation, no significant atrophy. You think of a muscle disease. Then if there is a skin rash, it could either be dermatomyositis or amino acid tear synthetase. If there is no skin rash, think of polymyositis and inclusion body myositis and immune mediated necrotizing myopathy. Okay, you have specific autoantibodies for each and every disease that you should be remembering. Okay, right. So with this we complete the topic on the pathology and clinical features of inflammatory muscle disease. In the treatment, the first line is always going to be steroids. See, Harrison very clearly says that when the patient is not responding to steroid only, start the patient on immunosuppressive therapy, but many of the time we don't do that. What we do is we always start a steroid sparing agent. So the first line of therapy for a steroid sparing agent is going to be methotrexate or azathioprine. One single answer is going to be methotrexate. The next better option would be azathioprine. The problem with azathioprine is that the onset of effectivity would be taking about 6 to 18 months to show its benefit. Whereas among the second line therapies, the one which has a very faster onset of action is methotrexate. So always methotrexate is the steroid sparing agent of choice that is preferred. Apart from that, you can use mycophenolate mofetil, cyclosporin, tacrolimus, okay, and IVIG, especially in patients with necrotizing myopathy, rituximab in refractory cases. Okay, when you use steroids, always use IV steroids first, then followed by oral steroids. Do not taper the steroids faster because patients with muscle weakness would need a high dose of steroids for a longer time. So you have to be very cautious in tapering the steroids. The tapering protocol is given in Harrison. You can go through this. And though despite giving much and much of treatment, the response is usually incomplete. Okay, and sometimes you need to add even a higher dose of prednisolone, or you need to add a second line agent. So most of the time we end up in adding a second line agent. And your treatment should be based on your clinical examination, objective assessment of muscle power, rather than asking the patient, how are you? Have you improved? No, doctor, I am not improved. Okay, increase the dose of methotrexate. This should not happen. You have to do an objective clinical examination with a muscle examination chart. And you should not rely only on the CPK levels. Because CPK levels are elevated, please do not increase the dose of steroids or increase the dose of DMARDs. It is just a coexistent comparator to assess the muscle. Okay, and when you find no response to high dose steroids at least for a month or so, the patient is not responding properly, you need to consider a repeat biopsy. Okay, and one common differential between an inflammatory muscle disease and steroid myopathy we discussed last class, okay, on while discussing about lupus psychosis and steroid induced psychosis. Okay, usually when the dose is high, you develop myopathy, and here the enzymes are usually normal, and they have other features of Cushingoid syndrome, and there is no spontaneous activity or irritability in a patient with steroid myopathy. And as I told you, neck weakness is usually absent in patients with steroid myopathy. The drug of choice, second line of choice, is always methotrexate, which is followed by azathioprine, which is followed by mycophenolate mofetil. One advantage of methotrexate, it's faster action. The problem with azathioprine is bone marrow toxicity because of TPMT assessment and liver dysfunction. The advantage of MMF is that it lacks both renal and liver dysfunction. IVIG can be used as maintenance therapy for HMG receptor associated myopathy. Rituximab is used in refractory cases. Okay, and there are a lot of associations with infectious diseases like hepatitis C and myopathy, HIV and myopathy, which you must be knowing. Apart from this, in a tropical country, you should always think of a pyomyositis and parasitic myositis. When the patient is throwing high-grade fever, you have to think of pyomyositis. And when the patient is having eosinophilia and high Ig, urticaria, angioedema, that sorts of things with the muscle weakness, and if the muscle weakness is localized and focused, always do an MRI and see if there is any cyst lying inside. That is the parasitic myositis. Malignancies are common and it varies from different person to different person. In the Asian population, the most common malignancy is nasopharyngeal cancer. So this is again an important MCQ. So we had a lot of MCQs, about 10 to 100 MCQs from the same topic on inflammatory muscle disease. So this is very, very, very important, and I hope you like this video. Okay, so for the next session, we'll be having in detail discussion of inflammatory myopathies also, but I would like to finish the class faster and faster so that you people would be having time to sit and rehearse or revise these chapters as soon as possible. And thank you. It's bye for now from Dr. Vignesh. Learn rheumatology with Dr. Vignesh. Fun and fun and fun, and more classes to come on YouTube and more classes to come along with the association with Assured Medical Foundation. It's bye for now from Vignesh from Apex Center for Rheumatology, Senior Consultant Rheumatologist at Hanmakonda, Warangal, Telangana State. If you like this video, please like this video, share this video to your friends, and please put your comments on the comment box to give so that I can go and do more homework for improving the quality of the teaching. Yes, definitely I would come with beautiful slides in the upcoming sessions. Because of want of time, I'm trying to finish off the portion in a different manner as we are seeing here.